You see me, Dee?
Yes.
Excellent.
Oh, there's your patient. Hello, everyone. Thank you for joining us today for our webinar entitled Botulinum, Toxin and Movement Disorders. My name is Dee Tran, Communications Editor of the IAPRD, and I will be moderating today on behalf of the International Association of Parkinsonism and Related Disorders. We'd like to thank you, our sponsors, Ipsen and Merz, for their generous support in making this webinar series possible. Today is the second of a whole series of botulinum toxin lectures. It is our hope that you will be able to join us in the future as well. Today's webinar consists of a 20-minute presentation to be followed by 10 minutes of questions and answers. Please type in your question in the chat box at any time, and you can help us serve you better in the future by filling out a brief evaluation form at the end of the webinar. This webinar will be recorded and available on demand for 1 year at our website, www.iaprd.org. And now I would like to introduce to you Dr. Marianne Pathak. Dr. Pathak has been a staff neurologist at the Parkinson's and Movement Disorders Institute in Southern California since 1999. He has participated in numerous clinical research studies, co-authored a patient-oriented book on living with dystonia, and provided medical illustrations of injection techniques for the manual botulinum toxin therapy. And with that, I would like to welcome Dr. Pathak. Dr.
Is everybody seeing my slide at this point? Mr. D. Tran?
We can't see your slides, Dr. Pathak.
Okay, here it comes. How about now?
Looks good.
Great. Thank you for the introduction. I am Dr. Pathak. The Parkinson's and Movement Disorders Institute has recently been renamed the Trong Neuroscience Institute here in Orange County, California. One of the things that we have done several years ago is to put out this book, The Manual of Botulinum Toxin Therapy, and a chief editor is our proprietor, Dr. Daniel Trong. And I was a contributor to this book. I was a chapter author, although not the chapter that we're dealing with today. My chief involvement with this book was as the illustrator, and almost all of the illustrations you see today are illustrations that I prepared for this book. Given that my audience is already probably consisting mostly of neurologists and other experienced clinicians, I'm going to dispense with talking about dystonias in general, or oromandibular dystonia in general, and jump right into the discussion of the different types, which are listed here. We have jaw clenching with its particular muscles of involvement, jaw opening with a different set of muscles. Some of these muscles can act in concert to cause jaw excursion, either forward protrusion, backward retraction, or lateral movement to either side. There's also involvement in other facial muscles and oral muscles, most commonly the tongue, which can either protrude or retract, and other facial and neck muscles. When that happens, it becomes more of a segmental type of dystonia. And I hope that with the assistance of my two model patients today, my mock patients, both living, wave to the camera, and my non-living mock patient, that I'll be able to show you how to inject some of these. Books typically classify oromandibular dystonias into these nice, neat categories. But the reality is when you see a patient, they occasionally come to you with a straight jaw clenching dystonia, as a young woman recently did to me. She was malnourished and dehydrated for about a week or so. It had come on suddenly. And it was a straight jaw clenching dystonia, pretty straightforward. But they usually come with a variety of movements or mixture of all of these types of dystonia. And the dystonia can be static, that they're stuck in one position, like the jaw clenching, or they can be more dyskinetic, which is various movements going on and on. And what you have to do is assess each patient and decide which muscles you're going to treat and inject. And this involves careful observation of the patient. Have the patient sit quietly, close their eyes, turn the lights off in the room, and instruct them not to fight their movements, but just let it go, let it come out, and observe them for several minutes. You can use provocative measures. You can have them open and close their fists. You can do some alternating movements with the hands in their lap. Sometimes these movements are set off by something in the mouth. So candy or chewing gum in the mouth can help elucidate these movements for you, so you can decide which is the most important movement or which is the strongest component of the dystonia, and then select the muscles you're going to treat first. Obviously, you don't want to treat every single muscle first. You want to be conservative when you start and treat only the major muscles involved, maybe one or two sets of muscles, probably bilateral, and then see the patient back in 6 or 8 weeks and plan your next round of injections. Things change. What I always tell patients is that getting Botox for this stuff is like Goldilocks. You get it right the third time. I'll also touch on guidance for these muscles, which is mostly anatomical, especially for the muscles that are external to the jaw and cranium. And I personally use EMG guidance for muscles that are inside the jaw. Other people use ultrasound. Doses and dilutions. The 3 types of toxins I use for this are Xeomin and Botox and Dysport. Xeomin and Botox, typically with the 100-unit vial, I will use a 2 ml dilution, and that affords me precision. It limits diffusion into adjacent muscles, and it allows me to control the dose of toxin for each muscle. I find when I use less than that, such as 1 ml per 100-unit vial, then it becomes very difficult to gauge the precise 1/10 of a cc or smaller injections that are needed into each muscle. Harder for me to do. And then for the Dysport, the multiplication factor is approximately 3.5 for each unit of Botox. So I'll jump right into the common jaw clenching type of dystonia. The 2 muscles that you would treat first are, number 1, the masseter, which clenches and superficial fibers may slightly protrude the mandible, and the temporalis muscle, which comes from the side of the skull, the temporal and parietal bones, and inserts onto the coronoid process of the mandible. I'm going to show you that in a second. Here it is. Let's get a pointer, laser pointer. So we have a masseter muscle, there's a parotid gland overlying it, and the temporalis muscle. And I'm going to go ahead and show you how to approach these muscles in the patient. I'm going to have her switch seats with me. So most protocols for using landmarks to find the masseter muscle use the earlobe as a starting point, but some people don't have an earlobe, or they have low-hanging earlobes. If you find a good picture of Clint Eastwood, you'll see that he has no earlobes. I prefer to use either the tragus or the notch between the tragus and the antitragus. I believe that's the intratragal notch right here, if everybody can see close enough. And you draw an imaginary line between the corner of the mouth and the intratragal notch. Then you can simply have the patient clench their jaw, and you can palpate easily the front anterior border of the masseter muscle. And you can palpate it all the way up to the zygomatic arch. The posterior border is, you can unclench. The posterior border is defined by the angle of the jaw. You want to keep your injections below this line, about 1 centimeter above the angle of the jaw. And what you do is you take this muscle and you draw 2 imaginary lines. You trisect the muscle into vertical thirds, and your injection points will be 1 centimeter above the inferior margin of the mandible, here and here, and then 1 in between and slightly above, again, staying below that imaginary line. I know what you guys are all thinking. Why am I not maintaining social distancing protocols with my mock patient here? And I can tell you it is because we daily share the same bubble, I believe is the term. And we're not really doing injections today. This is a safe way to inject. It avoids the marginal mandibular branch of the facial nerve. It avoids the buccal branch of the facial nerve, and the injections go right in between. So a very safe way to inject. I typically advise you, if you haven't done a lot of these, to go ahead and use either ultrasound or EMG localization for this at first. And I did so for the first few years, and now I no longer do. Am I still screen sharing? Or have I stopped?
You're still screen sharing.
What are you folks seeing? I'm trying to get rid of my laser pointer.
We're seeing oromandibular dystonia jaw clenching figure.
Great. All right. Are you seeing a bigger picture of us now?
Yes.
Okay, so this is a bigger picture. This might be more visible to you. Here's the imaginary line between the corner of the mouth and the intratragal notch. This is the anterior border of the masseter, the posterior border of the masseter. I've trisected the muscle, and I've gone 1 centimeter above the inferior margin of the mandible and made 2 injection sites here and 1 here. You can pop up. And what I found that after a few years of, or maybe a year or 2 of doing that with EMG guidance, then I no longer even needed EMG guidance. And even if you go through the parotid gland, it's not detrimental to the patient. Okay, sharing the screen again and moving on. Here's a good reference if you want a more detailed instruction on how to inject the masseter and avoid the common pitfalls and side effects. And then that brings us to the forgotten muscle, what I call the forgotten muscle of jaw clenching, because it's on the inside of the jaw. It's the medial pterygoid, and I'll go straight to the picture of it. The medial pterygoid starts on the inside surface of the mandible, and you can see it in this illustration. It's kind of a lighter shade ghosted figure that contrasts with the lateral pterygoids, which you can see plainly in the open here that are a darker color. Here's a illustration from an old edition of Gray's Anatomy that shows a cutaway of the jaw, and that's where the medial pterygoid muscle is. and I will show you that also on my mock patient here, that the medial pterygoid occupies this space from the inside of the mandible to the pterygoid plates here. So you can imagine if this muscle contracts, it's going to cause clenching of the jaw. The first two muscles I would treat in jaw clenching are the masseter and then the temporalis. And if that's not enough and it doesn't work out and it's not doing the trick, then maybe go after the medial pterygoid. And obviously that's because this is a deeper muscle and you'll get more side effects by affecting local muscles adjacent to it with your toxin injection. So as you go deeper, the perils grow greater. And then that brings us to jaw opening dystonia. We already saw the lateral pterygoids. You'll see another illustration of them. The lateral pterygoids are involved in opening the jaw. The lateral pterygoid has a superior and inferior head. It's the inferior head that causes most of the problem. And then you're going to see an illustration of the submental complex, which includes all of these muscles listed here. And then also what I call the forgotten muscle of jaw opening, which is the platysma. So back to this illustration, these are the lateral pterygoids. You can see that when these muscles contract, they will assist in jaw opening, and they will also slightly protrude the jaw forward. They are internal and they're accessed over the mandibular notch. So this U-shaped opening between the coronoid process and the condyle, which forms the temporomandibular joint. In this illustration, the zygomatic arch has been cut away, sort of just to expose it more. But you can see it here in my mock patient. Right here is the opening where you can access the medial, the lateral pterygoids. And this is easily done. I'm going to show you my mock patient again. Side, put your right side this way. I feel along the zygomatic arch right in front of the tragus of the ear, and I ask her to open her jaw, open and close, and you can easily palpate the temporomandibular joint and the condyle of the mandible. And then just a centimeter straight in front of it, straight in front of the tragus, is where that opening of the mandibular notch is going to be. If you come farther forward, you'll be able to feel the coronoid process. Go ahead and open and close your mouth again. And there, I can feel the coronoid process. I can feel the TMJ. Right in between them is the opening. And you can insert your needle perpendicular to the skin. It doesn't have to go far. It may penetrate through the masseter, after which it will hit the medial and lateral pterygoids. Pitfalls of this would be to hit, there's a maxillary artery that goes through there, and hitting the maxillary artery might cause a hematoma. That's pretty superficial, and it's fairly difficult to go much farther using a regular EMG needle. This is a reference for injecting the medial and lateral pterygoid muscles. It's on the NIH website. It's a great paper, and there's a great open access video that you can watch. The author of this paper is a oral and maxillofacial surgeon, and he advocates an intraoral approach to treating both of these muscles. So I
Dr.
recommend it.
Pathak, sorry, could you share your screen? We can't see the reference.
Let me share my screen again. Here we go. There you go. And I'll put it on slide view. So this is the reference. It's on the NIH website. It's an open access article. It's got an open access video. The medial and lateral pterygoids can be approached percutaneously from the outside. I think that's the way most neurologists would do it, but if you prefer an intraoral approach, you can watch this video. And then I just want to mention other muscles of the face will be involved very often. Facial grimacing, and these can all, if the platysma muscle, which you see down here, becomes involved, it can also cause movement of the jaw and head. And I'm going to ask my mock patient to demonstrate the platysma muscle for us. I want you to pretend you're really cheesed off at me, and I want you to grimace like this. And you can see that she's protruding the platysma muscles down here, and these can be approached just under the skin at several injection sites if need be. I just don't want them to be forgotten. And before I go further, I also want to stand on my soapbox for the masseter muscle. It's actually an important muscle to treat if you are using Botox to treat migraine patients. It's often overlooked as a contributor to headache and migraine and jaw pain. And then other dystonias may include lateral excursion of the jaw. And sometimes it's hard to remember which muscles are pulling to what side. It's easy to remember, however, that the muscles that are on the outside of the skull will pull the lower jaw, the mandible, ipsilaterally. And the muscles that are on the inside of the jaw will pull the muscle contralaterally. So if you have a patient with right lateral excursion, I use myself as the demonstration, right lateral excursion, then the muscles to inject would be the right temporalis and the right masseter and the left medial pterygoid and left lateral pterygoid. And moving on to other types of dystonias, if you have forward jaw thrusting, like so, you would want to treat the medial and lateral pterygoids. If you have retraction of the jaw, you would treat the posterior fibers of the temporalis muscle, and you can treat the masseters and the anterior digastric muscles. Tongue thrusting is a difficult thing to treat. What you have to do is treat the geniaglossus muscle, and it's the posterior fibers of the geniaglossus that are responsible for thrusting the tongue forward, like so. And you can feel these if you stick your thumb under your chin and just push your tongue against the back of your teeth. And you can feel it bulging. That's the entry point for the geniaglossus. You will go through the muscles on the floor of the oral cavity, and I highly recommend using EMG to do this. You'll hit that first layer of muscle, you'll go through it, and then you'll hit the geniaglossus, which has a different EMG sound. And with a little practice, you can hit it fairly regularly. And of course, you would want to use a very low dose, highly concentrated injection there because you have the greatest risk of causing side effects such as dysphagia and dysarthria when you do that. I have not treated anybody for tongue retraction dystonia. You'd have to treat the anterior fibers of the geniaglossus muscle, which, as you can imagine, would cause a great deal of dysarthria in any case. There are also pharyngeal dystonias, which occur in the soft palate. This is a view of the soft palate muscles from the back. It's back to front. And this is a view of the soft palate muscles from the front, where you would inject, and some injection points at the palatopharyngeal arch for palatal tremor and palatal dystonia. But I have to say that these injections are the most for being fraught with side effects, as you can imagine, dysarthria and dysphagia being foremost among them. Very difficult to treat and leaves patients less than fully satisfied. I'm going to move back a little bit and show you about injecting the digastric muscles and the tongue for the tongue thrusting dystonia and mouth opening dystonia. I'm going to have my mock patient come back. Here she is. So to get the anterior belly of the digastric muscle, I'd like to use my non-living model, but it has a hyoid bone, but the hyoid bone is not in the correct anatomical location. My living model does have her hyoid bone in the anatomical location, and we find that hyoid bone, mark it, draw an imaginary line to the angle of the jaw, and an imaginary line just under the chin. This encompasses the submental and the digastric triangles of the anterior neck. If you can see that, I hope my head isn't in the way. The anterior belly of the digastric muscle lies just perpendicular to this side of the triangle, moving towards the chin. This muscle, I recommend EMG guidance, and you can activate the muscle for the EMG by just having the patient open her mouth against a little bit of resistance. And to inject the tongue, and I'm trying to suppress the urge to make some comment about the sharpness of this patient's tongue, because I fear that if I do so, that we will soon be occupying separate bubbles. But in any case, once you identify the muscles at the floor of the mouth, you have the patient just close the teeth lightly and push her tongue against the back of the teeth, and you will hear the staccato motor units of the geniaglossus muscle, which you can easily just break into by pushing the needle in a little bit further. Approach to the geniaglossus muscle. Am I getting better at going back and forth between screen sharing?
Yes, definitely.
Also, if this model looks familiar to you, this is your presenter. I took a selfie of myself back before selfies were a thing. And that brings us to blepharospasm. This is one of our patients in our clinic who actually sent a selfie of himself to show us what was happening to him. And you can see that with the blepharospasm, it is different from a person just squinting their eyes shut. And this is why. You can see that the forehead muscles, the frontalis muscles, are contracting and the eyebrows are raised upwards and arched because the patient is actually trying to get his eyes open. but the orbicularis oculi muscles are clenching shut. So I actually just took his selfie and I traced out this line drawing to make that as apparent as possible. You can see the patient trying to hold their eyes open, but they can't. This is some anatomy of the orbicularis oculi muscle. I'm just going to skip over this slide and show you the injection points so we can finish up here. These are called the pretarsal injection points for the pretarsal part of the muscle, and these are called the preceptal injection points for the preceptal part of the muscle. The closer you get in to the pretarsal part, the less diffusion you have to adjacent muscles. What's not shown here is that the zygomatic minor muscle is almost contiguous with this outer edge of the orbicularis oculi muscle. And if you bring your injection points too far out, you're going to weaken that zygomatic muscle and you're going to drop the smile on one side or both sides. You'll have asymmetry and droopy face. So I typically use these 4 injection points closer to the pretarsal part of the muscle. Does that bring us up to about 20 minutes?
Yes, that's fine, Dr. Pathak.
Good. I'm going to go ahead and end my talk there. I want to thank you all for listening, and I want to thank my mock patients, both non-living and living, who you can see by the last slide presented, has accorded me her time and her patience and tolerance.
Welcome.
Well, thank you, Dr. Pathak, for such a wonderful presentation. It's quite humorous as well. I do have a question from a Dr. Patel, and the question is, how do you approach the medial pterygoid?
Oh, well, let me bring back my mock patient and I will show you. Are you seeing me full screen? I think I've stopped screen sharing. Good. Okay. Let me have her sit down. I have my approach instrument here for demonstration. I'm going to have her come up nice and close. So to approach the medial pterygoid, you can actually, if you'll excuse me just a second, if you want to feel this muscle on yourself, all you have to do is find your facial artery pulse. Find it right here. Take your thumb, stick it under your jaw, way up in there, and then let your tongue relax and retract it back into your mouth just a little. Then start clenching your teeth together. As you do that repeatedly, you will feel the medial pterygoid muscle contracting and bulging, contracting and bulging. The approach to the muscle is the same, pretty much right where the facial artery is. I insert my needle just till it contacts the periosteum on the inferior margin of the mandible. Then I retract it just a little bit, move inward, and then push up. I always use EMG when approaching this muscle, and I want to be as close to the inside surface of the bone as I possibly can be. The farther I am out here medially, the more problems the patient is going to experience later. So you just want to slip it over the edge of the bone and go straight upward. In previous years, I had tried approaches that came in this way from the side. They didn't work out good. So I go straight up right to here, right where my thumb was and right where this pencil is. I hope that answers your question.
Okay. There's another question from Dr. Stepanchenko. And the question is, how do you treat patients with persism, and what is your approach?
So treatment of bruxism can be the same as treating the jaw clenching dystonia. I first start off with just one muscle, just the masseter muscle, in the manner that I described. If that doesn't do the trick, I treat the masseter and the temporalis. And I haven't needed to go into treating the medial pterygoid for these patients at all. The doses, by the way, for jaw clenching in the masseter muscle can range anywhere from 12.5 units of Botox / Xeomin and multiply by 3.5 to get a Dysport dosage, up to a high of 50 units. So we start off conservatively, treat one muscle. If that doesn't work, treat two, and then following the Goldilocks principle, if that absolutely doesn't work, get it right the third time.
And Marianne, do you see another question? I saw it, but I can't find it.
There's a question, where is the landmark for anterior and posterior fibers of Geniaglossus?
So anterior fibers, I have not messed with. Anterior fibers, obviously, you could do a oral injection. The method that's described is that the tongue is held with gauze and the fibers are injected directly. I haven't done it to anybody. I can guarantee you you're going to cause a lot of maybe swallowing difficulties, but definitely some dysarthria. The posterior fibers are the same as the injection for the anterior belly of the digastric muscle, defining that triangle hyoid bone to angle of the jaw to point of chin, bisecting that triangle perpendicular to the bottom edge of the triangle, and going through that digastric muscle, through the mylohyoid muscle, and right into the posterior fibers of the Geniaglossus. And again, you can palpate these if you close your mouth and just push your tongue against the back of your teeth. You can easily find where those fibers are.
Also, just a question about how to inject for jaw tremor.
So jaw, again, it depends on the direction of the tremor. If it's an up and down tremor, you would probably want to inject masseter and temporalis and maybe medial pterygoids. But since with this tremor, you're going to be injecting all around, you need to be very conservative with your initial dosing, and then see the patient back, see how they're doing, up the dose next time. You probably are going to need doses that are towards the low end of the range.
Okay. And have you injected the tongue itself for tongue protrusion?
I have. I've injected the posterior fibers of the Geniaglossus. You inject one on each side. And again, very conservative dosing, 5, 10, maybe 15 units on each side. You have to be very conservative about this and progress as you go along with each successive injection session, because patients are often less than satisfied with the overall results. It's very difficult to get a very satisfactory result, but I have done it and it has worked for patients. And what I tell the patient is, you can expect that I'm going to reduce your tongue thrusting by 37.5% to 62.5%. And that's a reasonable goal.
Okay, one last question, and it's about the approach to jaw opening dystonia, and how do you identify the lateral pterygoid?
So lateral pterygoid, I'm not going to try the patients of my live model again. I think I'm going to give her a rest. I'm going to go to my skull and show you where the lateral pterygoids are. This is the mandibular notch, which is between the condyle and the coronoid process. It can be palpated by putting your finger on the tragus of the ear and asking the patient to open and close their jaws. easily palpated here. On most patients, you can also palpate the coronoid process if they open and close their jaw. Halfway between those 2 points is this football-shaped opening, which is under the zygomatic arch and over the mandibular notch. You want to stick your needle straight in there, perpendicular to the skin, and you want to use EMG guidance when you do that. I wanted to find out, like, what kind of trouble can you get into doing this? So I attached this 37.5 millimeter needle to this ballpoint pen, and I just stuck it through there right up to the hub, putting the hub where the skin surface would be. And I wanted to see what I could possibly hit in here that would create mischief. And what I found is I can easily reach the foramen ovale. And if you'll remember what goes through the foramen ovale, it's the mandibular division of the fifth cranial nerve. So wouldn't want to hit that. If I really pushed into the skin and angled backwards, I can actually reach the carotid canal. We don't want to do that. There's no reason to stick a needle in that far. You're going to go through the masseter, maybe the parotid gland, maybe the masseter, and then you're going to hit your lateral pterygoids. Again, use EMG guidance and have the patient open their jaw against a little resistance, maybe thrust it forward a little bit against resistance to activate those muscles, and you're going to hear it after you've gone through the masseter, which if the patient is opening their jaw, the masseter will be relaxed. You won't get any signal from there. You'll hit those lateral pterygoids, you'll get some signal. There you make your injection, no need to go deeper.
One more question just came in, Dr. Pathak, and that is, in patients with jaw opening dystonia and lingual dystonia, what is the recommended dose for Geniaglossus if we inject both lateral pterygoid in order to reduce the risk of dysphagia?
So I would start with a dose, Xeomin and Botox dose of 12.5 to each of the lateral pterygoids. And again, you're probably injecting those inferior head of the lateral pterygoid, which is the inferior head is what you'll almost certainly hit, and you're going to go right over the top of that mandibular notch. 12.5 on each side. The Geniaglossus, be very careful. Maybe no more than 10 or 12.5 units on each side of the Geniaglossus, and use a high concentration to limit diffusion into adjacent muscles.
Okay, well, that's all the questions we have. And so thank you again for a wonderful presentation today, Dr. Pathak. And thank you all the attendants today for joining us for the webinar. And as I mentioned before, this webinar will be on demand, available on demand at iaprd.org for 1 year. So again, thank you, and hope you could join us next time in our webinar series. Bye-bye. Thank you.